We'll go ahead and get started. Our first speaker is Dr. Jordan Dozier. He is a thoracic surgeon at Ochsner Medical Center. He's been part of CAGLA since last year, and we're very happy to have him. He did his medical school at Ross University, followed by a surgical residency at Rutgers in New Jersey. He did a research fellowship at Memorial Sloan Kettering, and then his thoracic surgery fellowship at The Ohio State University. So he's going to talk to us about updates on the management of mesothelioma. So, Dr. Dozier.
Thank you very much. Okay, good afternoon. As you said, Dr. Dozier. I work here at Ochsner as a thoracic surgeon, and today I'll be talking about updates in the management of mesothelioma. I have no disclosures. Malignant pleural mesothelioma is bad. All right, so it's not a landmark statement, but all the cancers that we're talking about throughout the course of this conference, they're all bad, but malignant pleural mesothelioma is particularly bad for a couple of reasons. So 5-year survival is low at 10%, and that's actually an improvement over the last 10 to 20 years. And so when you compare the same disease process in a different body cavity, so mesothelioma within the abdomen, we see survival of 65%. Life expectancy is also low, so average life expectancy is 4 to 18 months. So you can see what I mean when I say bad. But why is it so bad? Okay, so the disease has a long latency period. So most patients show no symptoms until 20 to 50 years after exposure. And so, unfortunately, the older the patient is at the time of diagnosis, the worse the survival. Secondly, early stage symptoms are usually mild or non-existent. So when symptoms do occur, they usually occur at a later stage of progression. And even more challenging, the symptoms are very nonspecific. So a dry cough, fatigue, gradual decrease in exercise tolerance are symptoms that you could just excuse for just old age. And so these may be ignored by the patients, but they're also may be ignored by practitioners, because as physicians, when you hear hooves, you may think a horse. You don't necessarily think that a zebra's there. And finally, the incidence of pleural mesothelioma is very low. And so I suppose that's a good thing, but because there's only 3,000 new cases a year compared to 240,000 new cases of lung cancer or breast cancer, there's few clinical trials, and it's been difficult to establish a universal standardization of care. So the goal of this talk will be to try to review what is the current management and what's on the horizon. But before we get into that, I know we have a mixed crowd here, so just a few of the basics and really brief overview. So the pleura is made up of 2 layers of mesothelium tissue. So the inner layer, which is the visceral pleura, covers the lungs, and the outer layer, which is the parietal pleura, lines the inside of the chest wall. And in between these 2 layers is a narrow space, and this is called the pleural cavity or the pleural space. And mesothelioma is a cancer of that lining. And because it's a lining of the chest, the tumor is capable of invading essentially everything within the chest. And so that means you can have disease confined to the pleural space, as you see in this picture. But you can also have disease that invades the lung, the pericardium, which is the lining around the heart, the diaphragm, and many other critical structures within the chest. And this is how these look on gross pathology as a specimen. So here, this is, you can see the compressive effect of the tumor, which is the white substance, pressing on this greenish brown substance, which is the lung. And this is why our patients have shortness of breath, because the tumor is restricting the lung's ability to expand. Here you see some invasion of the visceral pleura, or the lining of the lung, and finally invasion of the pericardium, which is tumor encasing the heart and the major vessels. But what causes mesothelioma? Most of you probably know the answer because you watch daytime TV, right? So mesothelioma, the number one cause is asbestos. So 80% of all cases are due to asbestos exposure. And so the reason why there's so much asbestos exposure, then the early 20th century, there was this is a real cartoon advertisement, advertising the heroic qualities of a magic mineral, asbestos. And so this was used a lot in different projects, home makeover projects, and was used with impunity. And so it wasn't until the 1960s that all of a sudden there started to be a rise in mesothelioma cases. And it wouldn't be until the 1980s that this link was put together and there was some legislation basically stopping the use of asbestos. There are some other causes, non-asbestos, mineral fibers, chemicals, radiation. These are all risk factors. Smoking isn't a risk factor. There is a synergy with asbestos and smoking for lung cancer, but smoking is not a direct risk factor for mesothelioma. Okay, so we're going to go through the management in the form of a clinical vignette. So our patient is a 70-year-old, never smoker, history of prostate cancer. He worked as a mason for 40 years. And he presented to the emergency department complaining of just right arm and axillary pain for 3 months. A chest x-ray was performed and showed a small pleural effusion. So what's the next step? Well, this is what the National Comprehensive Cancer Network, or the NCCN, says is the next step. This is their most recent guidelines. And so with a recurrent effusion or pleural thickening, patients should get a CT chest, thoracentesis, or pleural biopsy to establish a diagnosis. So that's exactly what we had. Our patient underwent a CT chest, just like every other patient in an emergency department in this country. So the patient luckily got a CT in this case, and it showed a right-sided pleural effusion, which is the green arrow, pleural nodularity, which are the red arrows, as well as a right anterior mediastinal node, so in front of the heart, and a 1.6 centimeter left hilar node, so those are the blue arrows. And when you switch the CT to lung windows, the patient also had a 1.7 centimeter right middle lobe nodule, as well as nodularity along the fissure. So these are all very concerning findings for a malignant process. So the patient did undergo a thoracentesis. We got 200 cc's of blood-tinged fluid that was sent for cytology and ended up being mesothelioma, specifically epithelioid type. So before we dive further into the case, just a brief detour about the different types of mesothelioma. There's 3 subtypes, epithelioid, biphasic, and sarcomatoid, which are based on the relative proportions of epithelial and spindle cells. But it's important to talk about histology because compared to other cancers, the histology really plays a big part about prognosis and the different treatment algorithms. So with epithelioid, which is more epithelioid cells, luckily this is the majority of cases, up to 60%. There's high grade and low grade, but these are much more responsive to our treatments. Data, which I'll show in a bit, shows that it's much more responsive to surgery and survivals are longer. And so putting the chemotherapy and the responsiveness to surgery as longer overall survival. Conversely, all the opposite can be said for sarcomatoid. So lower survival, these patients don't get surgery, and they don't really respond to chemotherapy. And then the biphasic is kind of a mix of the two. This is just a graph showing the relative survivals, so the marked epithelioid with higher survival, sarcomatoid with really poor survival, and the biphasic right in the middle. So we've established our diagnosis. The next step recommended by the NCCN is that this case should be managed by a multidisciplinary tumor board at a center of excellence with expertise treating mesothelioma. So that's what we did. And in our tumor board, this patient was recommended to have an endobronchial ultrasound, or an EBUS, which is a bronchoscopy with an ultrasound where you can look at the lymph nodes, as well as a PET CT. And so the EBUS, the lymph nodes were sampled, and fortunately all negative. We also got a PET scan, and a PET CT is important because additional sites of disease are picked up at least 10% of the time. And not surprisingly, we saw that there was PET activity on the right side, but the left side was concerning because that was also PET avid. And there was also some, not pictured here because this is still, there was some avidity along the diaphragm as well. So with these findings, we had reached a hard stop at the crossroads in the management of this patient. And so we expected the avidity on the right, but the avidity on the left is a critical determinant in the staging and subsequent management of our patient. So staging is going to be straightforward and follow all the same standards as other TNM classification, right? No. So most tumors, right? So most tumors, when you're talking about a T stage, you're talking about a very descript size. So if I have a 3 centimeter nodule, it's a 3 centimeter diameter circular golf ball in my lung. But with T stage and mesothelioma, we're talking about the extent of the disease. So a T1 disease is going to be just that ipsilateral pleura that we discussed. T2 involves invasion onto the lung or onto the diaphragm. And a T3 tumor starts to invade the endothoracic fascia or the ribs, and so in a single resectable area. So I can remove 3 ribs, right, and I can replace it with a patch, or I can replace it with some rib platings, but I can't remove, the entire chest wall. So that's a single resectable focus. Same thing with the pericardium. And T4 basically are things that can't come out. So like I said, I can't take out the entire rib cage. I can't take out a piece of the heart. I can't take out the spine. So those are T4 lesions that are more invasive. When it comes to the lymph nodes, for lymph nodes, previously this followed non-small cell cancer, so mediastinal lymph nodes or central lymph nodes were considered N2, but this was changed as recently in 2018, and this is basically where N1 disease is anything on the same side as the tumor. So if you have the right-sided disease, like our patient, any lymph node on the right side is going to be N1. Conversely, N2 is going to be metastasis to the contralateral side. So if I had a left side lymph node or lymph nodes above the clavicle, those are going to be your N2 disease. So as I mentioned, we're at a crossroads, because if that left-sided lymph node that was PET avid is positive, that's going to be the difference between N1 and N2 disease, and that's going to be the difference between stage 3A and stage 3B. And if you return back to the NCCN guidelines, you can see that this red box, if you're stage 3A or epithelioid, that's a patient that you're going to work up towards surgery and potentially a surgical, cure. And whereas 3B or 4 is going to be treated like sarcomatoid. This is not a surgical patient, and you're going to treat it either with just chemotherapy or palliative therapy. So it's a big determining crossroads. And so applying that to our patient, we had to figure out what's going on in that left-sided node. So I performed a VATS. I took that lymph node as well as other lymph nodes that I saw. And fortunately, they were all negative. So assuming your patient is physiologically fit, such as ours, and they're in good shape, you're now going to proceed as if this patient's a good surgical candidate. And this is always going to start with neoadjuvant chemotherapy. Okay, so again, just a short detour to talk about first-line neoadjuvant therapy and the landmark studies that establish these regimens. So this is going back to 2004. Vogelzang et al. Published in the JCO that they compared pemetrexed and cisplatin or Alimta and cisplatin with just cisplatin, and they showed a 3-month survival benefit, not even. And that was good enough to become standard of care. And so not much changed until 2016. There was a kind of a change where we discovered that patients would respond to Avastin, which is a VEGF inhibitor. And again, these are incremental improvements, 18.8 months versus 16.1 months. So still pretty dire outcomes. And so, nonetheless, our patient went with standard of care and had cisplatin Alimta therapy. But because the toxicities, as well as the aggressive nature of these disease, they can essentially act as a stress test because it takes time to go through chemotherapy. And then if the patient's able to tolerate the chemo and there's no progression, they may have a favorable tumor biology and may be able to tolerate the aggressive surgery ahead. Should they finish chemotherapy, though, we have to make sure there's no progression that we're not seeing. So the recommendation is a repeat PET. So that's what we did in our patient. And we saw stable disease in the right chest, but we also saw some disease along the diaphragm. We couldn't tell if this was on the diaphragm or under the diaphragm. And that makes the difference between just T2 disease versus M1 or metastatic disease. So he had to go through another procedure. So we underwent a diagnostic laparoscopy. There were some nodules. They were sampled. Unfortunately, they were negative. So these are all the different tests that you can order for these patients, and these are all the tests that were ordered in our patients. So we don't routinely get all these tests. There are some places that get all of these tests for all of these patients. And so the question is, why such an elaborate workup? Why not just take it out? And the reason is because of the difficulty of these operations. They're extremely morbid, high-risk operations, and high mortality associated. So let's talk about the surgeries. There's two operations, the extrapleural pneumonectomy, or EPP, and the pleurectomy and decortication, and these are both done with curative intent. Okay, so what's different about these? The EPP involves, like it says, extrapleural pneumonectomy, so removal of the lung, as well as the pleural lining, the parietal pleura, as well as the pericardium and the diaphragm. So a big surgery, what we call a big whack in our world. And so you're taking the patient's lung, there's a huge physiological strain, and so this is really chosen for just younger, healthy patients. But as I said, this is not a disease of the young, so pleurectomy and decortication came along, and so spares the lung. You essentially peel the lung off, peel the skin off of the lung, so that visceral pleura, take the parietal pleura, and spare the lung. There is something called the extensive pleurectomy and decortication, where if there's some limited disease of the diaphragm or the pericardium, you take that, but you don't take the lung. And finally, let's talk about what's the same. So the goal for these operations, you're never going to get an R0 resection where there's no cancer at all. So the goal is really that you don't see any macroscopic disease. So there's no obvious disease when you look into the chest, and we're okay with a microscopic resection, which is an R1 resection. The data shows, historically at least, that if you have some type of surgery and you make it to that point, there's improved survival, with survival anywhere between 17 to 25 months compared to what we discussed earlier. And then there's, in both of them, a role for radiation. We'll briefly go through that. So radiation therapy, there is no role for monotherapy, so just radiation therapy. You're always going to give that in combination with either chemotherapy or surgery. It's commonly given as palliative therapy, so if a patient has chest wall pain or brain mets, there's sometimes a role for radiation. There is some data that shows after extrapleural pneumonectomy or removal of the complete lung that you can do whole chest radiation, so you're radiating the entire chest field, and that this decreases local recurrence rates. But if the lung is still there, there's an increased risk for pneumonitis or inflammation of the lung because you're radiating it directly. But there is some exciting things that we're now doing. It's called, one of them which is IMRT, which is intensity modulated radiation therapy, where you can pick what's a no zone and a go zone. You basically are able to map out, you want to be able to treat the tumor, you don't want to be able to radiate the lung. And so it does show increased 2-year survival when combined with surgery and chemotherapy, but there is that increased risk of pneumonitis, up to 30% of patients. Okay, so let's talk about the surgery. So when comparing EPP, which sounds objectively like a larger operation, but we wanted to kind of prove it. So this was published in 2008, comparing the two. And they showed intraoperative mortality was higher with an EPP, 7% versus 4%. And they showed that PD versus EPP, that there was a better overall statistically significant survival difference. So that's that lower curve, but really not a huge difference. But the main thing was the mortality perioperatively. And so another study was done after following this. They said, okay, if it's so aggressive and there's so many patients dying from this operation, should we be doing it at all? And so this was the Mars trial. This was published in 2011. And essentially they had 50 patients that were able to be randomized. And surprisingly, they showed some concerning things. So median survival was higher in the patients who didn't have surgery. Okay, so basically just chemotherapy. The quality of life was better in patients who had no surgery. But even more alarming than what the previous study showed, they showed 18%. So 1 out of 5 essentially patients was dying perioperatively after EPP or removal of that lung. and a 70% almost complication rate. So these are alarming numbers, and so not unexpectedly, the EPP has fallen out of favor. This is a study out of MD Anderson that really aimed to drive the point home. And again, they showed improved median survival with pleurectomy and decortication, 22 versus 15 months, and a perioperative mortality, similarly 11% versus 0%. Okay. So we'll go back to our case. So our patient, again, 70 years old. There is additional data that shows that patients who are 70 do even worse with the EPP, so our plan was a pleurectomy, decortication, and removal of some of the diaphragm disease. So we went in, we did an extended posterior lateral thoracotomy. We noted dense adhesions between the lung, those two different pleura, so the visceral and parietal pleura were essentially completely fused, and so the lung wasn't free-flowing in the chest. And so we tried to mobilize the lung, but unfortunately we weren't able to develop a plane or be able to get the lung freed up without causing major injuries to the lung or bleeding. And so we realized a pleurectomy decortication wasn't going to be possible, and because the data shows that EPP, the patient would do potentially worse, we actually had to abort the surgery. So after this $1 million workup, and this patient going through all of these ups and downs, unfortunately this patient still wasn't able to get an operation. And so what do you do now? In the old days, or when I say old, I mean within the last 4 or 5 years, the only other option for this patient was some palliative radiation. And fortunately, there's a new study, this was published in 2022, that looked at, this was published in the Annals of Oncology, and they looked at checkpoint inhibition. And so we've heard a lot about checkpoint inhibitors throughout this conference, but just a brief review, essentially you're removing the brake from the T cells to be able to really attack the tumor cells. So they looked at nivolumab and ipilimumab versus cis and Alimta. And they had some pretty surprising and exciting findings. So overall, and again, these are unresectable patients who are not surgical candidates, and they showed that overall survival with immunotherapy was 18 months compared to 14 months. So not a huge difference in historical data, but what they did show that was really exciting is that in your sarcomatoid patient, again, this is the patients with the much lower overall survival, they showed 18.1 month overall survival compared to 8 months survival with chemotherapy. So that's a 10-month survival benefit. So that's kind of, in this world, when you're talking about months, that's a big difference. And so because of that, this has led to Nivo-Ipi becoming first-line therapy for patients who have unresectable disease. And so because of that, encouraging findings, there's lots of trials currently looking at immunotherapy, both in salvage therapy in patients who are unresectable, as well as in neoadjuvant. And the question is whether or not down the line will immunotherapy replace chemotherapy for neoadjuvant therapy. All right, so just a brief couple of slides on something a little bit more radical, some novel therapies for mesothelioma. And so we've heard a little bit about CAR T cells throughout the meeting, but CAR T cells are commonly used in hematologic malignancies and basically involve taking a patient's own T cells and modifying them to attack a certain protein on a tumor cell. And so you see on the bottom left, there's a T cell attacking a tumor cell expressing mesothelin. And mesothelin is expressed on 80% of all mesotheliomas. And so where I did my research at Memorial Sloan Kettering, Dr. Prasad Adasamili developed a clinical model with mice where we inject tumor cells into the mouse's pleural cavity, and it behaves just like human mesothelioma. So it spreads along the surface of the pleura, it invades the lymph nodes. We're able to image it to be able to monitor treatment. So after injecting the tumor cells, we take those CAR T cells and inject them directly into the chest of the mouse. And the data was pretty impressive and led to a phase 1 trial. So these are the results of his phase 1 trial. This was published 2022. So this was a first-in-human study of regional CAR T cells. And so there was intrapleural injections, and these were either done through an indwelling catheter the patient already had or image-guided via CT scan. And 40% of these patients actually had CAR T cells in their blood. So the T cells weren't staying in the chest. The body was responding to them and making all their T cells in the peripheral circulation express these CARs. And so that was exciting because we saw that in the mice. In addition, in the trial, he added it with checkpoint inhibitors, so pembrolizumab, a PD-1 inhibitor, and they showed median survival in this phase 1 trial is 24 months. So that's higher than anything else we've seen. Again, it's phase 1 trial. It's not randomized. But what's really exciting is they had 2 patients that had a complete metabolic response. And so what you see on the far right is in June 2017. This is after the patient received the CAR T cells. There was no progression of disease. But 3 months later, after checkpoint inhibitors were given, you see there's no PET activity. So at least from a metabolic standpoint, there's no evidence of disease. So if we could figure out why these patients are responding and who's responding, this may be something exciting for the future. So in summary, malignant pleural mesothelioma is a challenging disease with low survival rates with lots of room for improvement. Patients should be treated at high volume centers, so high volume in parentheses because of the low overall incidence, but they should be treated in high volume centers. Surgical candidates should be carefully selected through preoperative evaluation. And when comparing pleurectomy and decortication has a less morbidity, lower mortality, and improved overall survival when compared to extrapleural pneumonectomy. Thus, if there is a role for EPP, if at all, it should be just in young patients with few comorbidities. And finally, there is certainly some optimism regarding immunotherapy and novel agents. Thank you. I don't know, are we doing questions at the end, or how do we?
We can probably take some questions now.
All right, take some questions if there are any. No? All right. Yes?
For the CAR T therapy, do they have to go through the same procedure as hematologic CAR T? Like they have to have their response to the cells?
Yes.
So do they run the risk of having progression, I guess, during that period of CAR T?
Yeah, so there is a similar protocol. They have to be pre-treated with cyclophosphamide, and there is the same kind of process of harvesting the patient's T cells, multiplying the patient's CAR T cells, and then modifying them with the CAR. So there is that same lag. But those patients are undergoing chemotherapy as well. So they're getting standard chemo Cisalimta, and during that process is when the T cells are being created.